Okay, this is part G for TBI GCS scale. Part 1 covered the reading from the book, from the textbook, Big Red. I added a little bit more than what these pages. I kind of went more into physical therapy management of moderate to severe traumatic brain injury during active rehabilitation. It talked about box 19.2, secondary impairments, which would include a DVT, hydrotopic ossification, pressure ulcer, pneumonia, chronic pain, contractures, decreased endurance, muscle atrophy, fracture, and nerve damage. So let's go and review a little bit on hydrotopic oscillation. Please hold while I grab some information. So, according to the beautiful Wikipedia, heterotopic ossification is a process by which bony tissue forms outside of the skeleton. In a traumatic heterotopic ossification, the patient may complain of warm, tender, warm swelling in the muscle and decreased range of motion in the joint served by the muscle involved. So basically, it's when bony tissue forms outside of the skeleton. So let's go and look at a few little pictures of that. Ooh, that doesn't look good at all. Right here. That is not a super scan. Okay, here we go. Heterotopic ossification. On imaging. Massive heterotopic ossification. Wow, that's no good. 5 months, 10 months. Heterotopic ossification here and here. There's some right here and here. There in the knee. Hip. Elbow. Looks like a knee. So, no bueno right here. So back to the PowerPoint. It's where bony tissue forms outside the skeleton. Okay, so let's move on. Those were secondary impairments that could happen with a TBI. DVT, heterotopic ossification, pressure ulcer, pneumonia, chronic pain, contractures, decreased endurance, muscle atrophy, fracture, and peripheral nerve damage. Table 19.1, characteristics of mild, moderate, and severe traumatic brain injury. Mild TBI. Loss of consciousness, 0 to 30 minutes. Moderate TBI, 30 minutes to 24 hours. Severe TBI, greater than 24 hours. The AOC stands for alteration of consciousness. So you have loss of consciousness, and then you have alteration of consciousness. So for a mild TBI, loss of consciousness is 0 to 30 minutes. But alteration of consciousness is less than 24 hours. Moderate TBI, loss of consciousness is 30 minutes to 24 hours, and alteration of consciousness is 24 hours or greater. Severe TBI, loss of consciousness is greater than 24 hours, and alteration of consciousness is greater than 24 hours. PTA stands for post-traumatic amnesia. Post-traumatic amnesia. Mild TBI, 0 to 1 day. Moderate, 1 to 7 days. And severe is greater than 7 days. Post-traumatic amnesia. The Glasgow Coma Scale. Mild TBI, 13 to 15. Moderate, 9 to 12. And severe, less than 9. And here's the Glasgow Coma Scale. Let's go ahead and copy paste that. And let's bring it over here. That way we can look at it while we're looking at the other one. Yeah, I think so. Okay, so for a mild TBI, the Glasgow Coma Scale is 13 to 15. So let's say no response is a 1, spontaneous is a 4. That's eye-opening. Best motor response, follows motor commands is a 6, no response is a 1. Verbal response, oriented is 5, and no response is a 1. So there are 3 categories: eye-opening, best motor response, and verbal response. So motor, verbal, and eyes. So to be a mild TBI, 13 to 15. So let's see, what could they get? They could get spontaneous eye-opening. They could get localizes motor response, which is a 5, and verbal response would be oriented to get a 13. So if they had confused conversation, which is a 4, and they have localized motor response, which would be a 9, they would need spontaneous eye-opening to get a mild TBI. So 13 to 15, mild. 9 to 12, moderate. Less than 9 is severe TBI. Let's just get rid of this. Okay, stop. Stop. Delete. Okay. Range shows Los Amigos levels of cognitive functioning. And I'm broken it down into categories. So there are 8 categories. You have 3 responses: no response, generalized response, localized response. You have 3 confused. Confused agitated, confused inappropriate, confused appropriate. And then you have 3 appropriates. You have confused appropriate, automatic appropriate, purposeful appropriate. So within those 3 categories, confused appropriate can be in both of what I'm grouping them, how I'm grouping them. Okay, no response is just the patient appears to be in deep sleep and is completely unresponsive to any stimuli. No response. 1. Generalized, patient reacts inconsistently and non-purposefully to stimuli in a non-specific manner. Responses are limited and often the same regardless of stimulus presented. Responses may be physiological changes, gross body movements, and or vocalization. So the key words, in my opinion, here for generalized response at 2 would be that they're inconsistent, they're non-purposeful, they're limited, and they're the same regardless of the stimulus present, and they're gross. You could even add a pretty good word. Let's go ahead and do that. Non-specific. I don't want that. Okay, non. Okay. I'm always transposing letters. You know, it's horrible. See why I do this off camera? Okay, non-Pacific. We have Pacific here, right? Okay, so let's move this word around. That way we're kind of visually inconsistent. So generalized and localized response, both of them are inconsistent. The difference between generalized and localized is generalized is non-Pacific and localized is specific. Okay? Patient reacts specifically but inconsistently to stimuli. Responses are greatly related to the type of stimulus presented. So directly related, and up here it said what? It's unrelated. Okay, so directly related, and up here the responses are not related. They're the same regardless of the stimulus presented. Okay? May follow simple commands such as closing eyes or squeezing hand in an inconsistent, delayed manner. So, inconsistent and delayed. I don't know if we could say unrelated. I might modify that. Let's go here. Okay. Confused, agitated, confused, inappropriate, confused, appropriate. There's 3 in the first category and 3 in the second category. The patient is in a heightened state of activity. Confused and agitated, that is not a good combination. Behavior is bizarre. And this is 4. This is 4. And non-purposeful relative to immediate environment. Bizarre and non-purposeful relative to immediate environment. Does not demonstrate among persons or objects. Is unable to cooperate directly with treatment efforts. Verbalizations frequently and incoherently and or inappropriately to the environment. Confabulation may be present. Gross attention to environment is very brief. Selective attention is often non-existent. Patient lacks short and long-term recall. Heightened state of activity. Confused and agitated. Well, heck yeah. 4. Confused and agitated. Bizarre. Unpurposeful. Relative to immediate environment. Does not discriminate among persons or objects. I don't care if you're, a person or a hairbrush or anything. They don't get it. Unable to cooperate directly with treatment efforts, well, of course. Verbalizations frequently are incoherent. Like, what the heck are you talking about, dude? and totally inappropriate to the environment. Dude, no, we're not doing that. Inappropriate to the environment. We don't do that in the gym. You know what I'm saying? Confabulation. I don't know what that confabulation means. We're going to go look at that. Gross attention to environment is very brief. In the gym, cannot concentrate, has no idea where they are, what they're supposed to be doing in the gym. Selective attention is often non-existent. The patient lacks short and long-term recall. You just told him what we were in here doing, and he was like 2 seconds ago. Still doesn't understand. Confused and agitated. Let's go look up confabulation because I don't know what that means. Please hold. Okay, I'm back. Confabulation. The unconscious filling of gaps in one's memory by fabrications that one accepts as facts. The clinical phenomenon, look how it shows the part of the brain. That's interesting. The disorder is striking false beliefs sustained despite contrary evidence. Bilateral medial frontal lesions, ? Spouses, examples. A spouse is an imposter. Hospital is a hotel or home. Yeah, I've seen some traumatic brain injury patients act like that, most definitely. So, confabulation may be present. Learned a new word today. Okay, let's move on to 5. Confused, inappropriate. So 4 is confused and agitated. 4, 5, and 6. 5 is confused and inappropriate. I think I would take inappropriate over agitated any day. Okay. Patient is able to respond to simple commands fairly consistently. Okay. However, with increased complexity of commands or lack of any external structure, responses are unpurposeful, random, and fragmented. Demonstrates gross attention to the environment, but is highly distractible and lacks ability to focus attention on a specific task. The structure may be able to converse on a social automatic level for short periods of time. Verbalization is often inappropriate and confabulatory. We learned that new word. Memory is severely impaired, often shows inappropriate use of objects like brushing their hair with a toothbrush or trying to brush their teeth with a hairbrush. They perform previously learned tasks with structure but is unable to learn new information. So 5 may perform previously learned tasks with structure but unable to learn new information, like using a walker. They've never used a walker before. They're probably going to have difficulty with a walker at 5. Verbalization is often inappropriate. They may say like inappropriate sexual stuff to you. They might think the nurse is a spy and coming in here to kill them with the medication. That's confabulation. Confabulatory. They can't remember what they had for breakfast or lunch. Memory is severely impaired. The structure may be able to converse on a social automatic level for short periods of time. Demonstrates gross attention to the environment, but is highly distractible and lacks ability to focus. So they kind of get that they're in the gym, right? But you just told them to reach for this cone and is able to respond to simple command fairly consistently. The patient can reach for the cone, okay, but they see another patient walk by. So they're going to lack the ability to focus attention on that specific task. These are the patients you want to see in a gym by themselves. If you have a second gym off to the side, this is the patient to take to that standalone gym for just you and that patient, or whoever you need to make sure it's a safe environment, like a PTA or a tech. So that is confused and inappropriate. 5. Let's move on to 6. Confused and appropriate. Okay, so 4, 5, and 6 is confused, confused, confused. Agitated, inappropriate, appropriate. Patient shows goal-directed behavior, but is dependent on external input or direction. Okay, so the patient says, I want to get up and go to the bathroom, but is dependent on external input or direction. So it's dependent on how he does that or how she does that. Follows simple directions consistently and shows carryover for relearned tasks such as self-care. Follows simple directions consistently. Okay, so how do you stand up? I want you to push up from the bed. I want you to reach for the walker. Those are simple directions. But and at this level, the patient can show carryover for relearned tasks such as self-care. Okay, so you taught Mary yesterday that she brushes her hair with this brush and she uses a toothbrush to brush her teeth. That this is how she stands up to the walker. So shows carryover for relearned tasks and self-care, such as self-care. Responses may be incorrect due to memory problems, but they are appropriate to the situation. Okay, so maybe the patient doesn't push up from the bed. Maybe the patient reaches for the walker because they see a walker in front of them and they want to walk to the bathroom. But they forget that they need to push up instead of reaching for the walker. So the responses may be incorrect due to memory problems, but they're appropriate to the situation. Past memories show more depth in detail than recent memory. So they can probably tell you something that happened 5 years ago and probably tell you more details. But something that happened right before the accident, they're not going to have the details related to how they were performing functionally right before the accident, or what kind of lifestyle they led. They will leave out certain details but they could go probably 5 or 10 years and provide detail. So what part of 6 is confused? The confused could relate to the memory problems, but they're appropriate for the situation. Responses may be incorrect due to memory problems, but they are appropriate to the situation. Confused. So they're a little confused of, what they were doing right before the accident, but they can give you appropriate, in the ballpark. It's appropriate to the situation. Okay. Let's see. Okay, so 4, 5, and 6. Confused, confused, confused. Agitated, inappropriate, appropriate. So you got to know these headings before you can get. So let's go back. No response, generalized response, localized response. No, generalized, localized. NGL. No, generalized, localized. Confused, confused, confused. Agitated, inappropriate, appropriate. Okay, so here's where we get some redundancy. Confused, appropriate, because now we have appropriate, appropriate, appropriate. So we have here 4, 5, and 6 is confused, confused, confused. And then 6, 7, and 8 is appropriate, appropriate, appropriate. You will never, ever forget this. I'm telling you. I'm drilling it into your head. Patient shows goal-directed behavior. So goal-directed, I know I want to get up and go eat lunch. But I'm dependent on the external input or direction. So we already went over this part. Confused and appropriate. Appropriate, it's time to go eat. I want to go eat. Confused, I don't know how to get there. Right? Or I don't know how to do that. Confused and appropriate. Now I'm moving to static. Automatic and appropriate. Patient appears appropriate and oriented within the hospital and home settings. Goes through daily routine automatically, but frequently robot-like. Patient shows a minimal to no confusion and has shallow recall of activities. Shows carryover for new learning, but at a decreased rate. With structure, is able to initiate social and recreational activities. Judgment remains impaired. So automatic and appropriate. So in familiar settings like the hospital and home settings, the patient can be appropriate and oriented. Okay, goes through the daily routine automatically. Okay, I get out of bed, I go eat breakfast, I go put my clothes on, I sit in my chair. At lunch, I go eat, I sit in my chair. At supper, I go eat, I sit in my chair. So goes through daily routines automatically, but like a robot. I'm going to go sit in my chair. I'm going to go eat lunch. Automatic, appropriate. 7. Number 7. Shows carryover for new learning, but at a decreased rate. It may take 10 days to get a patient to push up from the bed instead of reaching for the walker instead of 1 day. It may take 10 days to teach the patient that those shoestrings you do not have to tie. They're elastic. You just put your foot in there. Don't untie the shoe. Don't untie the shoe. Just put your foot in there. Okay? A long time ago, or not too long ago, they were untying and tying your shoe. Now they don't untie the shoe. They just put their foot in it. Okay? So eventually they can get it. Okay, I don't have to untie the shoe. I just put my foot in it. But it may take longer. So that's a 7. Automatic, appropriate. And with structure, the patient is able to initiate social or recreational activities. Time to go do bingo. Let's go play bingo. But judgment remains impaired. Okay, they don't get the fact that they can't go to Walmart and walk all the way around Walmart with their walker without knowing there's some place to sit down. Okay, they may think, hey, I can walk without this walker. I'm just going to the bathroom. Judgment remains impaired. They're automatic, appropriate. That's number 7. So now we're getting to number 8, which is purposeful, appropriate. Hey, we're getting there now. Patient is able to recall and integrate past and recent events and is aware of and responsive to the environment. Patient is able to recall and integrate past and recent events. Okay, so this is my daughter, and that's her husband, and they got married like 10 years ago. But they just had a baby 2 months ago. Oh, I didn't know you had a baby. Oh, you had a baby? You knew we had a baby, Dad. Oh, I didn't remember that. But when they get to an 8, the patient's able to recall and integrate the past. My daughter got married 10 years ago. And recent events, hey, they had a baby 2 months ago. He's able to integrate the past and recent and is aware of and responsive to the environment. Aware of and responsive to the environment. Understands that they're in the gym and understands they're in there to do therapy. Aware of the gym and responsive to exercising in the gym. They're not confused. They're ready to do this. Shows carryover for new learning and needs no supervision once activities are learned. Okay? So the patient's learned how to stand up, pushing up off the bed, standing up at the walker, walking with the walker to the bathroom, turning all the way around in front of the toilet to sit down, reaches for the grab bar. Okay, new learning. Has never used a walker before the accident. So now the patient understands they need the walker, doesn't need any supervision. They've learned how to use the walker. They may continue to show a decreased ability relative to pre-morbid abilities, abstract reasoning, tolerance for stress, and judgment in emergencies or unusual circumstances. They may continue to show a decreased ability relative to pre-morbid abilities, abstract reasoning, tolerance for stress, and judgment in emergencies or unusual circumstances. Okay, so 6, 7, 8. 6, 7, 8. Confused, appropriate. Automatic, appropriate. Purposeful, appropriate. Okay, so here we have no, generalized, and localized. The difference here is non-specific to specific. They're both inconsistent, but non-specific to specific. Non-purposeful, unrelated. Stimulus, the response is not related to the stimulus. Limited, no matter what. Okay, so same. So let's change this word. Same and limited. I want to do that. Let's put unrelated. Unrelated. I'm telling you, see why I do this. So unrelated, directly related. Gross. Simple commands but are delayed. Okay. Responses are gross. Okay. And then we already went through confused, 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 agitated, inappropriate, appropriate. It's going to take some repetition to get this stuff down, believe me. I will be revisiting these slides before I go take that test for sure. Or this video. Listen to my own self give a lecture to me, right? Still a little sip. Okay, box 19.4. General goals and outcomes anticipated for patients with severe to moderate traumatic brain injury in the acute stage. Impact of impairment is reduced. These are goals. These are things that you want to write your goals. Risk of secondary impairments is reduced. Motor function is improved. Joint integrity and mobility are improved or remain functional. Level of arousal and alertness is increased. Ability to improve physical actions, tasks, or activities is improved. Tolerance of upright postures and activities is improved. Functional mobility is improved. Safety of patient, family, and caregivers is improved. Patient satisfaction is enhanced. Family and caregivers are educated on patient's diagnosis, physical therapy interventions, goals, and outcomes. Care is coordinated among all team members. Okay. This is table 19.6, special considerations for confused and agitated patients. Consistency. Consistency is important. All team members, including family members, should interact and address inappropriate behaviors in a consistent manner. Remember that the patient is confused. To help decrease confusion, the patient should be seen by the same person at the same time and in the same location every day. Establishing a daily routine is very important. It is calming and reassuring to have a sense of familiarity. Additionally, orientation, person, place, and time should be provided frequently and in a non-threatening manner. At this level, it is often better to provide orientation information than to challenge the patient to provide it, particularly if the patient is not expected to succeed. Expect no carryover. Teaching new skills at this level is unrealistic. The patient may begin to perform a functional task such as brushing teeth or ambulating. However, this does not indicate a general learning ability because brushing one's teeth and especially walking are automatic skills with an ingrained neural network. The use of charts or graphs may be useful to help the patient progress each day. Without the use of such aids, the patient is likely to have no recall of the previous day's performance. Model calm behavior. The patient is likely to perceive and may reflect the demeanor of the caregiver. Therefore, it is important for the therapist to assume a calm and focused affect. The patient may not be able to control his or her behavior and may not feel safe. To help the patient feel safe, it is important for the therapist to be perceived as in control of his or her emotions and behavior. Expect egocentricity. At this level of recovery, the patient cannot be expected to see another's point of view. He or she will tend to think only of himself or herself, and at this point, it is unwise to stress the patient with attempts to do otherwise. Flexibility options. The patient will have a limited attention span and may not be able to concentrate on given activity for a very long time. It is important to be prepared with numerous activities. If the patient cannot be redirected to a selected task, it is appropriate to attempt to engage him in another. For example, it may be difficult for a client to tolerate a full constraint-induced therapy protocol. You might, however, be able to engage the client in a variety of upper extremity reaching tasks in various environments, allowing the patient's level of attention and tolerance to dictate the duration of each. Treat the patient at an appropriate age level. Give control to the patient when it is safe and appropriate. Control can be given while maintaining focus on therapeutic goals by phrasing questions as, would you rather play ball or go for a walk? This prevents situations where the patient chooses an undesirable or unrealistic activity if asked, what would you like to do? Or in the case where the patient simply answers no when asked, what would you like to? Provide safe choices for the patient. This allows the patient to feel that she has some control over the situation. It is important because the patient typically feels considered loss of control during prolonged hospitalization. Safety. Owing to the patient's often unpredictable and inappropriate behaviors, it is important to keep the patient and those interacting with him or her safe. In addition to utilizing some of the previously mentioned behavioral strategies, patients at this level of recovery may be kept on a locked unit in the hospital. Patients may require one-to-one staff supervision and assistance throughout the day. Environment. Initially, interventions should be performed in a closed environment with limited distractions. Open environments, such as a busy rehab gym, will likely to have too many distractions and can lead to increased agitation and limited ability to participate in the intervention. Progress to more open environments to challenge the patient as the patient improves. Okay, so this was for confused and agitated patients. Can you remember what number that is? Well, it's not 1, 2, and 3, because those are responsibles. Those are responses. No response, generalized response, localized response. So the next 3 are what? They are confused. Yes. So 4, 5, and 6 are confused. So confused and agitated, confused and inappropriate, confused and appropriate. So confused and agitated patients are what? 4, 4, 4, 4. Okay. Table 19.5, Principles of Experience Dependent Neuroplasticity. Principle, use it or lose it. Failure to drive specific brain functions can lead to functional degradation. Use it and improve it. Training that drives a specific brain function to lead to an enhancement of that function. Specificity. Hate that word. The nature of the training experience dictates the nature of the plasticity. Repetition matters. Induction of plasticity requires sufficient repetition. This is not what we are giving our patients because of insurance. Intensity matters. Induction of plasticity requires sufficient training. Intensity. Time matters. Different forms of plasticity occur at different times during training. Salience matters. And every time I hear that word salience, I think of Dr. O'Brien. The training experience must be sufficiently salient to induce plasticity. Salient. What's important to the patient? What do they think is important? Age matters. Training-induced plasticity occurs more readily in younger brains. Transference. Plasticity in response to one training experience can enhance the acquisition of similar behaviors. Interference. Plasticity in response to one's experience can interfere with the acquisition of other behaviors. So transference, plasticity in response to one training experience can enhance acquisition of similar behaviors. Interference, plasticity in response to one's experience can interfere with the acquisition of other behaviors. So enhance and interfere. And we are down to therapy. What kind of time we got going on here? Oh my gosh, 47 minutes. Oh my gosh. Okay. All right. Let's see here. Okay, so we're now on therapy ed. Traumatic brain injury. Etiology. Mechanism of injury is contact forces to the skull and rotational acceleration forces causing varying degrees of injury to the brain. Localized lesions of the cortex. You know what? I might make this on part 3. Yeah, let's do that. Let's make it part 3. Part 3. Probably not tonight, though. It's 6:11. It's almost my bedtime. I think tomorrow I get up with a fresh mind and do part 3, because part 3 is talking about different parts of the brain, and I don't want to be tired when I video this. The frontal, the parietal, the temporal, and the occipital. Really need to dig into that one. I pulled some pictures. So I took this table and I divided it: frontal, parietal, temporal, occipital, and spinal cord injury. That was just at the end. I'm going to go ahead and delete that. It was at the end of the PDF, and that's not what this is about. We'll get rid of that. But anyway, so catch me on part 3.